right, everyone can hear me fine? Okay, so my name is Lynn Carmichael. I'm the Senior Director of Computational Bioinformatics at Sanford Imaginetics. I'd ask you to bear with me tonight for a couple of reasons. For one, Neil Burkle was supposed to give this talk, however, he was called away on an emergency. So for everyone else's reference, be careful when one of your colleagues has an active practice as a clinician, because patient needs are more important than tech conference talk needs. So be prepared for that. On the other end, in addition, while we've made a lot of advances in modern medicine, we still have not cured the common cold. And I'm relying on Dayquil to keep me upright through this entire conference, including this talk. All right, so I want to kind of present our vision for precision medicine and prevention, specifically in rural healthcare. So Sanford Health is a large healthcare provider with clinics and hospitals stretching from Minnesota through the breadth of Montana. And as you can see, it's grown very rapidly over the last 10 years, trying to incorporate a bunch of disparate healthcare practices and hospitals and clinics across a very wide area of the upper Midwest and mountain states. We serve over 2 million people in over 130 towns and cities distributed over 9 states. So, excuse me. The goal is to improve the health and prevent disease with personalized plans of care by integrating genetic medicine and primary care. This is all really philosophically derived from the observation that health is a person's adaptation to an ecological niche, as Barton Childs wrote in Genetic Medicine, A Logic of Disease. And so with that in mind, you could determine that a given person's health is derived from a set of different determinants. There is their genetics and biological background, their family background, a wide variety. Their physical environment they live in, the kind of work they do, their education, their economic and income status. A variety of things have an impact on what someone's current adaptation to their ecological niche is. And so what we're interested in doing is trying to take into account all of these determinants to kind of maximize the health of a given person within the niche that they happen to occupy. And so from the standpoint of genetic medicine, it exists on a continuum between thinking of things in terms of disease and in terms of health, which is essentially the degree to which you are currently adapted to the ecological niche you find yourself in. So on the one hand, in terms of diagnostics and treatments, you have precision medicine, where you try to personalize a treatment for a person's current condition that they are suffering from. At the other end, you have precision prevention, where you're trying to, through analysis of genetics and other factors, figure out what is likely to be potential risks for a person within your healthcare system, and hopefully be able to provide interventions that will help them to lower that risk or avoid that kind of a problem. So our goal is to produce what we call an integrated risk profile that takes into account these determinants of health for each of the population that we serve, and use that to determine to what extent there are interventions that are possible or education that's possible to help them to maintain their health or to improve it. One of the mechanisms for allowing that is essentially mapping these determinants of health onto established ontologies so that we can then compute on them to calculate this integrated risk profile. And on the one hand, you have diagnostic testing, which I'm sure a lot of you are familiar with, in terms of looking at the genetics of a cancer patient to figure out what possible treatments might be more effective for them. And on the other hand, you have preemptive testing, which would be screening. And so on the one hand, we might do exome or genome sequencing or RNA-seq to do transcriptome analysis, expression analysis, all the way through to what we call the Sanford chip, which is a targeted panel, a genotype array, and pharmacogenomic testing. And these are used to kind of help create this risk profile to determine, is it likely that they might have a rare disease based on specific mutations that they have that would be considered medically actionable predispositions for a given disease? Or do they have mutations that would be counterindicative to taking certain pharmaceutical interventions, or might mean that some would be more effective for them? So the difficulty that we have, and that was basically placed on me and my group, is how do we build the laboratory to support this? This is a large amount of data. It's not just genomics. It's not just genetic sequencing. It's a whole panoply of information that's coming from a variety of sources. So how do we support this as a laboratory? So some of these determinants we can't really do a whole lot about. How you were raised by your parents, not a lot that we can do. So we kind of look at specific ones that we can either measure and use to guide treatment or try to influence through education to the extent that's possible. And with the ultimate goal is provide a platform for the community of healthcare providers within our system to have this computationally assisted interpretation tool that they can use with each other to kind of share their information and insights informed by this platform as to what the ideal set of treatments and information can best improve their customers, their patients' health. So we basically start with this idea of the computational laboratory. The computational laboratory has a variety of inputs, as I've discussed. There's direct inputs from the primary care providers and other clinicians through the medical record. We use one chart. There is patient-provided information. We have a self-assessment tool that they can use to answer questions about maybe their family history, their habits, their environment, et cetera. There's also informed consent education and forms for them to fill out to understand what kind of tests and screens we might put them through that can provide information. And then on the other side, you have a lot of your more standard testing, whether this is looking at cholesterol levels or doing a whole genome sequence or running a genotyping array through the medical genetics laboratory. All of these things can provide inputs to this computational laboratory that we are building. Then they will be mapped to ontologies that represent sort of the phenotype of the patient and the environment that the patient lives in. And then that provides us with a more standardized set of data that we can then use for our analysis and computation. All right, so there's a lot of challenges that we face in trying to put this together as a real-world thing. The first is just the sheer complexity. There's a wide variety of data sources, a lot of pipelines. Jan was mentioning the standard genetic sequencing and genotyping pipeline. That's certainly one component of it. There's RNA-seq analysis, and there's processes for rationalizing medical record data, natural language processing, et cetera, a variety of tools, a variety of databases. Anyone who's worked in this field knows that there are, for any given problem you have, there's probably 15 different solutions that someone has come up with for it. And so we need a way to manage that and be able to access it readily. There's the scale of the data. I talked about over 2 million patients. In a perfect world, we'd be able to run all of them through these clinical screens we're developing. But even if that doesn't happen, even tens or hundreds of thousands, looking at hundreds of thousands or millions of genetic variants and other phenotypical and environmental information is just a lot of data to be processed, which is storage is a problem and the computation is a problem. Because this is a clinical application and not a research application, this all needs to be validated ahead of time. There has to be technical validation. We have to be able to demonstrate the statistical attributes of every single component of the entire system, whether it's running a DNA extraction on the one hand or some complicated AI process on the other. We have to be able to tell the CAP inspector, this is what the predictive value is of this component, and here's the tests that we ran to verify that that's the case. This requires a lot of documentation. It's an extremely rigorous process to go through. Then at the end of it, and for me probably personally the most important thing, is just the operational aspects. I would be perfectly happy to never spend another day looking at a Terraform, Chef, or Ansible script for the rest of my life. I don't know how many of you have had to do that, but when you're talking about the scale of storage and computation and testing, and I talked about validation, that goes right into that. Everything has to be very formally versioned. This is a giant headache if you have to go through and write tests to make sure that your tests work correctly, for instance. So that's another major headache that we have. So we explored different approaches to solve this problem and eventually came to the conclusion that Databricks would provide a good platform for this computational laboratory, partially because of the tight integration with Spark, which gives us the computational model that works at the scale we need to operate, and part with the Databricks notebook and the Databricks systems that make a lot of the other problems I talked about a lot more tractable for us. And so you can kind of categorize our data that we're operating on into a few major areas. You have kind of on the left, you see there's a lot of discrete data and kind of arbitrary medical records. I don't know if any of you have ever tried to look through EMR data. This is not a fun thing to do. Finding ways to extract meaningful information out of that we can compute on is a major problem. That's a significant machine learning computational problem. On the right side, you have large-scale omics in a general sense, whether it's genomics, transcriptomics, proteomics, metabolomics, phenomics, exposomics, et cetera, et cetera, et cetera. If I were Neil, I could go on for another 5 minutes. And then ultimately trying to map this into a tractable format, ideally as ontologies, understanding that might not work out in the end. But if that were the case, we could use more graph analysis and graph reasoning algorithms that are available on the Spark platform and turn a hairy, difficult problem into something that's at least possible. So to kind of look at what we've done so far and kind of to some extent, what we use is a proof of concept test when we were looking at Databricks and other platforms is genomics. So we basically have the Sanford chip, which is a genotyping microarray with over 600,000 assays. And so to validate that as a clinical test, we needed to do a technical validation where we take the genotype results for technical replicates of given samples and then compare them to genotyping results from an orthogonal platform. So basically, we took and did whole genome sequencing on over 400 samples to assess every mutation with a minor allele frequency greater than 1% in the 1,000 Genomes Project and do a technical validation on the Sanford chip for those same assays. Another thing that goes into the clinical validation and ongoing quality control is making sure that, especially for rare alleles that are hard to validate because it's hard to find someone who actually has that mutation, that the allele frequencies reported by the Sanford chip aren't significantly out of whack with what has been seen within that given source population, is another component that goes into assay validation and ongoing quality control. And finally, we're exploring it to take the next step where we start looking at polygenic risk analysis and associating patterns of gene mutations with given potential future problems that a person might have, diseases, cardiovascular disease, atrial fibrillation, et cetera, to calculate risk scores. So what Databricks provides us is a lot of benefits for doing a lot of this work. It's easy to incorporate a variety of well-known and commonly used libraries, as Jan mentioned in one of his slides, whether it's GATK or Hail or Atom or any of the others. You've got in Spark, you have the baked-in easy integration between data and machine learning, and with a lot of the libraries, you have Variant Spark, for instance, has a good integration between genotype data and machine learning algorithms that they have implemented. And then one nice thing with the Databricks notebooks is kind of the ease of collaboration and sharing information, which is actually critically important from the standpoint of creating clinical assays. As I alluded to earlier, we have to document everything very thoroughly. We have to explicitly spell out every single thing that's happening in a standard operating procedure document. And we have to have documented all of the validation tests that we're going to run to make sure that this works correctly and has some kind of clinical utility. Being able to add that side by side with the pipeline definitions within the Databricks notebook is a very good side benefit. So the main takeaways we had with evaluating Databricks were the simplicity of incorporating all the tools that we needed, all of the libraries, Atom, Hail, Variant Spark, custom libraries that we need, for instance, the libraries for parsing a lot of the raw data out of the lab, support for a variety of programming languages. I fought really hard to convince my team that they should just all convert to Scala. I lost that fight. So, all right, Stacy's arguing that maybe we can still convince them. I'm going to try not to, but so far there's a lot of Python holdouts, and R holdouts for that matter. The scalability of the platform of Spark and Databricks has even, like, just through our research and development, has proven to work well. When you're dealing with whole genome sequence and genotype analysis, you have millions of variants. The Sanford chip itself has over 600,000 variants on the chip. We want to run through 150,000 samples. That's a large-scale data analysis to extract information out of that. And even just through the course of the proof of concept, we had some people on the team looking at transcriptome expression analysis, and this is a very noisy set of data. It's hard to extract meaning out of that. And we were looking at 18,000 patients with over 60,000 transcripts that had been profiled. Basically a very hairy problem. And being able to use Databricks and Spark certainly helped to make that more reasonable. As I kind of already mentioned, being able to have the documentation in line and shared between all of the practitioners, all of the analysts and software engineers is good. You can even have the definitions for the testing built into the notebook definition. We have basically put in the standard operating procedure and validation sections. These can be automatically extracted into the necessary chapters for CAP validation. And also, as I mentioned, the easy DevOps, basically enabling automated testing and version control and a lot easier configuration and deployment. If we're running in a computation that requires a 10-node cluster, it's trivial to set that up and run it. If it requires a 500-node cluster, that's no more difficult than a 10-node cluster, unless you get an email from AWS saying you've gone past your quota. Not sure what's going on there. Anyway, so some use cases that we've gone through were, as I mentioned, the Sanford chip validation and quality control. We've already gone through that process successfully and have been starting to adapt that to Databricks for ongoing competency and proficiency testing. I also mentioned the transcriptome analysis for cancer diagnostics. And then a project that we're starting to work on that goes back to how I mentioned integrated risk profiles. The first step for that is to look at polygenic risk analysis for patients prior to having any symptoms of a problem and who don't necessarily have some devastating rare disease that you're trying to suss out, but rather just might have a predisposition to have a heart attack without any other symptoms at the age of 40. So this is an area that there's been a lot of work. With the advent of inexpensive genetic sequencing, it's become a far more tractable kind of problem, where we're getting to the point where we have enough samples that have been sequenced to get enough statistical power that genome-wide association studies can actually narrow down a list of candidate genes and candidate mutations that have a high probability of contributing to a given disease. So there's been a lot of promising studies, growing lists of risk-contributing mutations, and so we're working on this with collaborators and are interested in the possibility of adding additional sorts of information to increase the accuracy and kind of the personalization of this as a clinical screen. What if you incorporate medical records? What if you incorporate patient-provided self-assessment information? Maybe just have a nice, efficient way to bring in family history as part of the analysis rather than having it be a separate thing by itself. So these additional data dimensions can potentially increase the predictive value and possibly provide indicators for decision support systems for indicating to clinical providers, maybe this patient needs to have an additional test run to verify this potential risk based on their exposure to fertilizers or some set of mutations they might have. The requirements for this are along the lines of what we've already been talking about, essentially a unified data platform and scalable and repeatable analysis. So because there's a wide variety of data that we're looking at, it's heterogeneous. I think someone used the term data swamp earlier, I heard. Trying to turn that into a reasonable, rational, computable set of data is definitely a challenge, and we need a platform where that's relatively straightforward. So we've got, whether it's inconsistent medical records or free-form text that a patient or a doctor has entered in, self-reported information, you need to verify the reliability of it, and then the genome and various other genetic data that might be part of the record associated with the patient. It's at a large scale. Obviously, with a whole genome, you could have 2, 3, 4 million mutations and hundreds or thousands of clinical records that have been added. Image data might be part of it. So it has to be able to handle that, and it needs to have a common interface to draw this all into one unified analytical system or pipeline. And then this all needs to be scalable beyond just the size. The process for actually extracting out the patterns that are meaningful from the data is challenging. The idea is to use deep learning to evaluate the impact of this phenotypical or environmental information on top of the polygenic risk analysis that we do. And then we can cross-validate that with known outcomes that we have from patients who have consented to be part of various research projects that we have done. And then that will hopefully provide us with the thousands or tens of thousands of samples required to give us enough statistical power to confidently report what the impact of including these things is on any given clinical screen that we might develop. And so clearly this has to be a large-scale iterative process. It's going to be a lot of data scientists and bioinformatics experts and lab technicians and physicians working on this in a kind of highly repetitive, long-term process. So in conclusion, essentially Databricks provides us with the platform that lets us do all of these things, especially with its integration with Spark that lets us produce these large-scale data analytical pipelines that we need and at the same time document them and use that for getting through the strenuous process of cap validation. So basically, Spark makes it possible and Databricks makes it easy. Well, easier. Are there any questions?
Lynn, do you have any examples of like how this will affect a patient that comes into your health system? And obviously these data sets are coming together, probably for the first time. As far as a large-scale implementation, like how does it help a patient?
So probably the immediate effect is probably the rare disease variant screen and the pharmacogenetic screening. That a lot of places are doing that already. That's kind of the immediate impact. If you discover you have a mutation that gives you a predisposition to having a heart attack, well, start taking statins earlier. If you have a mutation that shows that you're not going to respond well to this particular psychotropic treatment, then that's probably not the one for you, and the pharmacist or the physician can recommend a different one. The next phase is going to go in with the polygenic risk score calculations. It's already looking at the results that have been found, like even just looking at cardiovascular disease, which is a really good example. There's 70, I think maybe now up to 120 genes or specific point mutations that have been found that significantly increase the likelihood that someone's going to have a heart attack just out of the blue, without having a high LDL cholesterol level, without having any other known evidence to suggest that. And yet if they have enough of these mutations in this family, they could, at the age of 45, just keel over into a heart attack. And the nice thing about it is if you provide them with statins, it's shown that prevents that from happening, just like it does for people with high LDL cholesterol. So it's a relatively low risk, low impact treatment that can be readily provided just with a relatively easy screen to detect what their degree of risk is for having that kind of a problem.
Awesome, thanks. Any questions?
Yeah, you mentioned validation, and I was just curious about, are you guys doing anything around like digital provenance and like a metadata or data catalog, those kinds of things?
That is, definitely something that we are currently documenting in a more manual process, which gives me nightmares at night when I try to go to bed, because that's a critical part of the whole clinical validation and going through CLIA and CAP is making sure that you can trace the provenance of all the patient data and all the reference data and all the annotation data that's going into it, absolutely. So it's definitely something that we're thinking about. Good. If you have a solution to my problem, I'd be happy to talk to you.
So in terms of repeatable analysis, so what kind of tricks or tips you can give us there? And also have a couple of other non-technical questions. Is insurance really interested in paying for the preventive screen test?
All right, so I'm going to let you in on a secret. Don't tell anyone else. One advantage that Sanford Health has, they also provide insurance to their customers as well as healthcare. They're a self-insuring organization, and we can also, for the chip, we can provide it at a low enough cost that a healthcare insurance reimbursement hopefully won't be too much of a problem.
Can they kick people out because of
because of the results? That is a very interesting question, and I'm going to say right now, I am not a lawyer. They give me these problems to work on, and me and my team, we work on them. That's not one of them. Yes? There's that too. So this is a part of why we kind of started down this path as an organization is the population that's served by Sanford is actually fairly unique within the United States. It actually is a fairly stable population. A very large percentage of people who are born at a Sanford Health hospital will live their entire lives within the same area and die within the same area that they were born in. And so one of the kind of the underlying returns on investment from this approach is if we can genotype someone at birth, we have that record, which can serve to help guide their healthcare potentially for their entire life without having to worry about efficiently transferring it to some other, EMS or some other healthcare system.
I think we got time for one more.
Yeah, so any tips on the...
Oh, sorry.
Sorry. So if I understand correctly, you make recommendations to doctors, right? Like if this patient should be treated. So does that, because medical landscape is kind of complex when you make recommendations.
Yes.
So does that have to go through regulatory? Because as I understand, 23andMe got in trouble because of...
So yes, this is not a direct-to-consumer screen. That's not what we're doing. This is all through their healthcare provider and through consultation with genetic counselors and their primary care provider. And all of the results don't go directly to a consumer. They go to their primary care provider and to genetic counselors. So all of the reports are reviewed by medical genetics laboratory directors and pharmaceutical directors.
And would the doctor then do the treatment or, the therapeutic intervention depending on the recommendation?
Yes.
Based on this?
Yes, absolutely.
Okay, thank you.
Sure. One of my colleagues is arguing for another benefit that we have. So all of the medically actionable predisposition variants that we detect, we validate them with Sanger sequencing as well, just to try to cut down the false positive rate, which is kind of notorious for a lot of these platforms.
Okay. Thank you very much, Lynn. That was an awesome talk. We appreciate it.